Sunday for Transplant, and this week we're very excited to have Dr. Vinay Nair join us from New York. Thank you for joining.
Great, thank you very much, and thank you for having me. I see a lot of people, so this should be exciting. I'm just going to share my screen. Give me 1 second. Go. Is that okay?
Perfect. Thank you.
Okay, wonderful. So today I want to talk about personalized approach to kidney transplant candidates with hematologic malignancy. It's definitely sort of an interest of mine, and it can be kind of a complicated topic, but hopefully by the end of this topic, we'll have some clarity on how to sort of approach these patients. So first, I have no financial disclosures. And so just to briefly go through the objectives, as I kind of mentioned, the idea is to figure out how to approach these complex patients, how to approach selection in these patients that have hematologic malignancies, just with some clarity. Summarize some current guidelines on transplanting patients that have these hematologic malignancies and approach to kidney transplant. And specifically, I will talk a little bit about lymphoma, myeloma, AL, and AL amyloidosis. So plasma cell dyscrasias, of course. And then some peri and post-transplant considerations when you're taking care of such patients. And then I'll be happy to answer any questions. So I like to start off with a case, and I don't have the fancy survey information, the survey link, unfortunately, but just to get everyone thinking, and this is a true story, actually, one of our patients. It's Mr. F, 76-year-old male, presents for a kidney transplant. His GFR is 14, and he has a living donor, and basically says he's not going to accept dialysis. His workup reveals lymphadenopathy for kidney transplantation. We do a biopsy of his lymph node, and pathology reveals follicular lymphoma, grade 1 to 2, stage 2, positive for lambda, CD19, CD20, CD10, negative CD5. And the question is, what would you do with this information? So 76, preemptive, 14 GFR, now has this lymphoma, right? His follicular lymphoma. So first, A, decline for transplant. He's got an active malignancy, right? And he's 76. B, treat the lymphoma and wait 2 years. C, give rituximab and then transplant him, CD20 positive. Or D, more information is needed. So I'd like everyone just to kind of think about this and put in their head, what they would probably choose. And then we'll go through the presentation at the end, come back to this question, and basically go over kind of what we decided to do, how the patient's doing. So how do you approach these patients? So the first question is, what do you want to see in terms of outcomes, right? And that depends a lot based on kind of your philosophy in transplant and what your center is okay with, right? So what type of survival is your center okay with? Is better than dialysis? A lot of people will argue that really, when you transplant someone, you should be comparing to the disease, outcome comparison to the disease. So if you're doing better than dialysis, well, that is a win, right? You've improved the patient's life if they're going to live longer than they would on dialysis. But the truth is, we live in a very regulatory world. So are you looking in your center looking for equivalent 1 or 5-year survival with the general transplant population or the diabetic population? I'm going to mention diabetes because, well, we transplant a lot of patients with diabetes, and they're complicated. They tend to have worse outcomes than, say, GNs or polycystic kidney disease. So that's a question that only you and your center have to really think about and ask. Larger centers might be able to take a higher risk. Smaller centers may not. Next, is immunosuppression going to make the disease worse? This is a hard question to answer, but there's some hints in the literature if immunosuppression is going to make the disease worse or not. Is there good hematology support to prognosticate and treat potential relapses? As we'll go over, some hematologic malignancies are very well characterized by recurrences and relapses. You have to expect relapse in certain diseases like myeloma, for example. And do you have good hematology support? And that doesn't necessarily mean at your center, but is there a hematologist you can kind of work with to kind of guide you through this, that you can brainstorm with? Next, how hard is it to manage a relapse or recurrence? And then finally, are there any guidelines to support your decision?